Welcome everyone to the series of our webinars dedicated to electrical impedance tomography and PulmoVista 500. So today is the first webinar of the series, and we are going to talk about the clinical benefits of regional ventilation distribution. My name is Margarita, and I'm the Regional Marketing Manager for Intensive Care at Dräger. So today I'm going to cover a few topics. So and before that, I just would like to quickly introduce myself. As I said, my name is Margarita Sinha. I'm the Regional Marketing Manager for Intensive Care at Dräger. I have been working with Dräger for the past 7 years in the field of critical care, intensive care in the regions Africa, Asia, Australia, and now I'm based in Middle East and Africa. I have been providing clinical, technical, and technical education and training in the field of intensive care and neonatal care. And today, during this workshop, we are going to address 4 main key topics. So first of all, I would like to try to answer, why do we even need to consider regional lung function? What are the advantages that we can get from the monitoring of regional ventilation distribution? Then I'm going to talk a little bit in more details about the PulmoVista 500, the electrical impedance tomography device that we have in our portfolio, and how we can bring this regional information to the patient bedside. Also, then we're going to have a practical demonstration on the PulmoVista 500, and we're going to discuss some of the cases in which PulmoVista can be particularly interesting in your everyday clinical practice. And I'm going to close this webinar with a short revision of the clinical evidence of the EIT, because I think for some it still is considered as a new technology, and I would just want to demonstrate that even this new technology, which has been on the market for the past almost 10 years, have received a substantial amount of clinical evidence. So let's start with the question, why do we even need to consider the regional lung function? And I think the answer is pretty clear. For all of you and all of us who work in the intensive care environments or are involved in the training in the intensive care environment or suppliers in the intensive care environment, we all know that patients who are mechanically ventilated, especially over the long term, they develop ventilator-associated, or they can develop ventilator-associated pneumonias, which can potentially lead to a longer hospital stay, and as a result, in the higher cost of care. Also, if we look at the mechanically ventilated patient, we can say, and that's not just statistics, these are clinically proven facts, that about 1/4 or 25% of all ICU patients would develop acute respiratory distress syndrome, which contributes to the mortality in the ICU. And only 50% of the long-term ICU ventilated patients are able to go back to normal life even after a year after discharge. So, and I think this pandemic with the COVID-19, we realized that the dangers and the challenges of mechanical ventilation, and especially with the recovery of from the mechanical ventilation, are extremely high. So, and therefore, our goals are in the ICU, and your goals to start with, your goals in the ICU, and as a result, our goals in the ICU is to reduce mortality, avoid ICU-acquired weaknesses, and reduce cognitive impairments. So what we're trying to do, we're really trying to reduce length of stay in the ICU, reduce duration of mechanical ventilation, as a result contributing to the reduction of ventilator-associated lung injuries and the development of ARDS. And we also want to ensure improved patient comfort, because we know that patient ventilation asynchrony can contribute also to the longer ventilation time. So if we look at the mechanical ventilation in the intensive care, the ARDS, the acute respiratory distress syndrome, might be, and almost in 80%, is associated or is a consequence of ventilator-associated lung injury, which is obviously caused by inappropriate mechanical ventilation settings. And as I mentioned, if we look at the clinical evidence, about 1/4 of every ICU, of all ICU patients would develop an ARDS. So we are looking at about 25% of the patients. So it's 1 out of every 4 patients. And surprisingly enough, 40% of all ARDS cases are not even being diagnosed at an early stage. And when the diagnosis happens, this sometimes becomes too late already. And if you look at the mortality of ARDS, sometimes it can reach up to 45%, of course, depending on the severity of ARDS. And almost 50% of ARDS survivors do not return to work after 1 year. So we're not just talking about the short-term complications in the ICU and the workload on the intensivist, respiratory therapists, and the nurses, but we're also talking about the long-term consequences of the quality of life, for the ICU survivors, for the patients who have stayed in the ICU. So let's have a look a little bit closer on the ventilator-induced lung injury, or VILI in short. So basically, there are multiple components that contribute to the ventilator-induced lung injury. And there's been, I think, mechanical ventilation has been in use since a long time. So different types of mechanical ventilation for different modes, but since about 50s, the clinicians started to look at what are the major contributors to the ARDS, to the ventilator-induced lung injury. And they have compared different strategies on how to ventilate their patients. So they started with the ventilation at low lung volume. So they opted for the low tidal volumes. And we see that at the end of inspiration, we had majority of the lung being aerated. But at the end of expiration, we were noticing that we have had almost 50% of the lung being consolidated. So inappropriate settings of a site parameter as PEEP, PEEP positive and expiratory pressure, was contributing to the development of the lung inhomogeneities, or in more common terms, to atelectasis trauma, when the certain dependent regions of the lung would collapse or would experience a delay in the ventilation. On the other hand, the clinicians also looked at the ventilation at high lung volumes. So it can either be with high inspiratory pressure or higher tidal volume per kilogram of body weight tidal volumes. And we see that the high lung volumes would contribute to the hyperinflation, and they would cause the overdistension which in return would translate into the damage of the alveolar capillary wall, and thus creating the potential for pneumothorax or breaking of this capillary wall. So basically, we know that we realize that the lower ventilation at lower lung volumes are potentially dangerous and contributing to atelective trauma. Ventilating with higher lung volumes are also dangerous and potentially contributing to the overdistension and such conditions as pneumothorax. And as a result, we would cause a extreme inhomogeneity in the patient's lung. And we would then need to look at how ventilation is basically being distributed in the patient lung, dependent on the inspiratory or expiratory cycle. So let's have a look at why to consider regional lung function. What are our general goals for respiratory support? What are we trying to do to achieve with mechanical ventilation? So first of all, we would like to achieve and maintain acceptable gas exchange. So at the end of the day, we need to ensure that we have correct oxygenation and we have appropriate CO2 washouts. But at the same time, we would like to maintain lung protective ventilation and minimize the adverse effects of achieving this gas exchange. So avoiding potential atelectasis, avoiding tidal derecruitment, and avoiding potential overdistension. We also want to control the mechanical power of the lung tissue, and we want to avoid the inflammatory responses that are induced by the structural damage of the lung tissue. And in the meantime, we also would like to treat the underlying cause of the lung disease. And if we look at the patient or at the CT scan of a patient who was diagnosed with ARDS, we have, at least on the picture on the CT scan, we have areas that are aerated. So there is air in their lung. There are also areas that are less aerated, and potentially, because we just a CT scan is done at one point in time, they might still be aerated, but they might experience so-called tidal derecruitment. So basically, at the end of inspiration, they would collapse fast, they would collapse, and at the beginning of inspiration, they would open again, which would cause the mechanical stress on the lung tissue, and thus, as a result, might contribute to the development of the viral trauma. And we have areas that are not participating in the gas exchange. This area is D, and these are areas that are completely collapsed. So, and that's how we see and know that our lung is inhomogeneous. So we usually do either an X-ray, a CT scan, or even potentially an ultrasound. So, and if we look at the very interesting publication in which the Japanese study group had looked at the volume controlled ventilation and whether this can prevent the injurious inflation during spontaneous efforts. So basically, they came to the conclusion that volume controlled ventilation it prevented the increase in the tidal volume, obviously because we have a strong volume target. but it did not prevent from injurious inflation pattern during spontaneous breathing. So, and they were referring to such conditions as pendulum, as such conditions as local volume trauma or tidal de-recruitment and re-recruitment. And I think it's quite an interesting observation, because when we talk about mechanical ventilation, especially in the adult ventilation world, we do tend to use the volume control modes more frequently, because we can control the tidal volume delivery, and we can control as a result the minute ventilation and the CO2 washouts. And we would use the lung protective ventilation strategies 4 to 6 milliliter per kilogram of body weight. However, nevertheless, and especially in spontaneously breathing patients, we would still see the localized volume traumas. And if we also look at the conventional way to optimize ventilation, we usually use global parameters. We refer to the compliance value, we refer to the tidal volume value, we refer, if we have available, transpulmonary pressure, inspiratory pressure. So basically, those are all the global parameters that we can get from the ventilator. And if we have a connection to the patient monitor, we of course have the information about the SpO2 as well. And we would try to ventilate our patients within this safe ventilation zone. So our target would be to avoid the zones of de-recruitment or atelectasis, and to avoid the zones of overdistension. And obviously, we would try, our common goal would be to offer optimal ventilation to avoid the alveolar collapse and avoid the overdistension. And however, sometimes it can be quite difficult to find those ventilation settings that allows us that. And that's why in some ventilators we have a function that is called low flow PV loop, which is considered as one of the recruitment techniques and the recruitment maneuvers, and also a maneuver that allows to identify the optimal PEEP settings for the inspiratory pressure, and basically the optimized ventilation settings. And if you look at the low flow PV loops, we have the information about the lower inflection point. So this is the point at which the lung opens up. We have the upper inflection point. This is, it could be either the beginning of the lung overextension, or it could be also the end of recruitment. So we don't really know which of the two, but we probably would not go higher than this upper inflection point. This is on the inspiration cycle. We also can perform similar analysis on the expiration cycle, and then we have this point of maximum curvature. And this is the point at which the lung can be potentially collapsing. And in this particular example, our point at which the lung, or our pressure at which the lung is opening, is lower than the pressure at which the lung is closing. So in this case, would we rather go for the PEEP setting of the lower inflection point, or would we rather go into the setting of the point of maximum curvature in order to avoid the atelectasis or the lung collapse on the expiratory cycle? And the answer to that question is not that easy, because we would need to look at what are the what is the maximum pressure that we can deliver to the patient? What is the transpulmonary pressure that we are delivering to the patient? What is the driving pressure? And what is the tidal volume? So we cannot really make a completely informed decision based on just the low flow PV loop. And also we have to remember that it's rather an invasive procedure, and especially in the patients with very unstable lung conditions, such as the patients with severe ARDS, we can only perform one low-flow PV loop maneuver in order to avoid further damage or further causing of the instability of the patient lung. Also, another question is this 6 milliliters per kilogram, is it really suitable for everyone? Or is there also a difference based on the patient conditions? And what this study is coming from, it's a relatively old study, and we see that it's coming from 2000s, so it's almost 20-year-old study, but it's still makes quite interesting discoveries. That potentially 6 milliliters per kilogram of body weight might not necessarily be the right answer to everyone. So we can see that here, for example, that the lower tidal volume and the traditional tidal volume, we see that the days after randomization, they are kind of going towards the same pattern. So we really need to consider a personalized approach, especially in the condition with severe ARDS. Also, there were researchers that were looking at the ventilator-induced lung injuries, even despite the low tidal volumes. So this particular study from 2007 from the Luciano Gattinoni group, they looked at the tidal hyperinflation during the low tidal volume ventilation in acute respiratory distress syndrome. And they looked, they basically compared the scientific subjects. So they were looking at the lung protective ventilation, which was at that time limiting the tidal volume to 6 milliliters per kilogram of body weight and limiting the plateau pressure to 30 centimeters of water. And these parameters are suitable parameters for a majority of patients to protect the lung from the development of ventilator-induced lung injury and potentially the development of ARDS. And also, however, what this study discovers is that patients that were characterized by a larger amount of collapsed lungs, so basically patients who had a significant portion of the lung collapsed or atelectatic, they were also exposed to this tidal volume and pressure limitation. However, they discovered that for those patients, the plateau pressure should be limited to 28 centimeters of water. And basically, the conversation started that the best ventilatory strategy should be ideally adapted to the size of the aerated lung. And that's when this notion of baby lung come into the play. So we have the areas of the lung that are collapsed, and we have the areas of the lung that are potentially overdistended. So we have a significantly smaller area of the lung that are participating in the normal ventilation. And if we're targeting the 6 milliliters per kilogram of body weight on a significantly smaller of the normally aerated lung tissue, then we might be contributing to the further development of the lung injury. But we only are able to realize that if we have the information about the regional ventilation distribution. And also another interesting study about the regional stress ratios and lung inhomogeneities, also from Luciano Gattinoni group. They came to the conclusion that the lung inhomogeneities are associated with the overall disease severity and mortality. And increasing the airway pressure decreased, but did not abolish completely the extent of lung inhomogeneities. So, and it's becoming extremely challenging to find the right ventilation strategy. It seems like we don't have one recipe for all patients, and every patient starts to require its own ventilation settings. And finally, this, I think, iconic publication from Luciano Gattinoni as well have compared 68 patients with acute respiratory distress syndrome. They went a whole lung CT during breath holding sessions at the airway pressure of 5, 15, and 45 centimeters of water. So basically, they were doing a CT scan during the a potential recruitment maneuver. And what they have discovered that in patients with ARDS, the percentage of potentially recruitable lung is extremely variable, and it is strongly associated with the response to PEEP. So that's when the conversation started about responders to PEEP recruitment maneuvers and non-responders. But having a ventilator only is very difficult. That's why, for example, even on this picture, we see that in this patient, the aerated area of the lung at 5 centimeters of water and the aerated area of the lung at 45 centimeters of water is not significantly different. So we can say that this patient potentially was not a responder to a recruitment maneuver. On the other hand, for this patient number 2, we have a much higher percentage of potentially recruitable lung. So the patient is responding better to the higher pressures, which can indicate that he is a responder to the recruitment maneuver. And that resulted in the notion that the airway pressures call for individual adjustments. But how many of you in your clinical practice have access to a CT scan during your recruitment maneuvers? Probably none. I would safely say none, because usually the modality of CT is located somewhere in the basement, and the ICU is located obviously on higher floors. CT does not provide continuous information at the bedside, and it's only at a single point of holding the breath. CT also only provides the information about the air content, but not of the changes of the lung volume. Yes, we can clearly say that the lung has air inside, but we still wouldn't be able to differentiate if the air changes in the lung with every breath. So potentially we will not be able to estimate the portion of the lung that are potentially over-distended. So, and if we look at the, if we look at the times when we need this assessment the most, it's usually at the bedside during the therapeutic intervention, either chronic or recruitment maneuver, and we would need this information continuously throughout the ventilation because the patient's status changes. So that's why we need to have a possibility to look for the typical signs of collapse in the recruitment. Either we can use the global parameters such as desaturation or reduced tidal volume, or ideally we would even look at the regional ventilation distribution. We would also look for the signs of overdistension, and we would look for the signs of the tidal de-recruitment or the delayed ventilation. But if we look at all of the modalities that are currently available in the ICU, like ventilator parameters, for example, Yes, they are continuous at the bedside, they are non-invasive, they are radiation-free, but they don't provide the information about the regional ventilation distribution. Lung mechanics, same. Oximetry, similar. Capnography, similar. Blood gases, they are not continuous. They still can be done at the bedside, non-invasive, they are radiation-free. Then we're getting into more complex modalities like chest X-ray or a CT scan. Then we can get the information about the regional ventilation distribution, but it cannot be done at the bedside, and it cannot be done continuously. So the question is there really a modality that that combines all of the benefits of being regional, continuous, bedside, non-invasive, and radiation-free in a single device? And the answer is yes. We have the possibility to use electrical impedance tomography or a PulmoVista 500. So let's have a look on the PulmoVista 500 and electrical impedance tomography. So this type of tool, assessment tool, can be used in the ICU. It can be used in the emergency departments. It can be used even in the OR, and it can be used on different population of patients. So we have recently introduced pediatric belts, so now we can look at even the baby population and the majority of the patient population in the ICU. You can see here we have quite large patients, we have smaller patients, so we have a diverse intended use for the PulmoVista 500. Also, if we compare the image projection of the CT scan and the AIT, it's quite similar. So we have the basically the reverse image. So if we look at the patient, then the right lung will be on our left, and the left lung will be on our right. So if we look at the patient's CT scan or the chest X-ray, so this would be our right lung, and this would be our left lung. So how do we do the measurements? We are using a belt with electrodes that is placed on the patient between the 5th and 6th vertebra. And the positioning of the belt is extremely important for the image quality. And once we're doing our practical hands-on, I will demonstrate to you the belt itself and the positioning of the belt. But for example, here we can clearly see, so if the belt is positioned correctly, we can look at the slides that we are most interested in. So in this case, the dependent regions of the lung. If the belt is positioned too low, we might have the artifacts of the diaphragm getting into the image. And then our images would not make much sense. So for example, here, we are moving the belt down, down, down. We of course have the heart and the mediastinum, and then we get really strange images where we have the blue, basically is the areas of the positive impedance, and purple color represents the areas of the negative impedance. And usually when you see the purple color, that would mean that our belt is not positioned correctly. So here we would already start getting the artifacts of our diaphragm. So the belt positioning is extremely important for the correct image generation. So how does PulmoVista create images, or how does basically EIT create images? So basically, let's have a look at the healthy lung. Here's we have the CT scan of the healthy lung. And if we look at the ventilation or the gas exchange in the different areas of the lung, we can see that all areas of the lung are normally ventilated. So we have in the ventral areas, the central and the dorsal are equally ventilated. And in that case, we would see something similar on the PulmoVista. So this is a tidal image, and this is basically how the air goes in and out of the lung. So the blue color means that there is air in that area. The black color represents that there is no air. So, and if we then look at the regions of interest, especially when we are trying to evaluate the patients with ARDS, potentially pneumonias, or even pneumothoraces, we would divide our image into the 4 regions of interest. And we would then translate it into the ventral, mid-dorsal, and dorsal areas. And usually, the distribution of ventilation would be about 35 to 40 in the mid-ventral and mid-dorsal, and then about 10 to 15 in the dorsal and the ventral areas. So basically, if your patient is in supine position, the dorsal areas would be the ones that are closer to the patient bed. So those are the dependent regions of the lung that are potentially prone to collapsing in the patient with ARDS. So, and if we look at the EIT sensitivity region, in contrast to a CT scan where we look at just one slice of patient lung, EIT captures a lens-shaped volume, and we're looking at approximately 10 centimeters of the width of this region of interest. And it basically represents a larger part of the chest, and basically this whole region contributes to the generation of EIT images. So that's why when we position the bell between 5th and 6th vertebra, we are getting the information about the dorsal areas and the mid areas of the lung. If we potentially position the belt too high, we might not have the right regions of interest. So our dorsal area might not be covered by this lens-shaped volume. That's why it's extremely important to have the right belt positioning during the EIT measurement. So let's have a look at the dorsal. How could it look on the PulmoVista when we have the dorsal lung collapse? So in the dorsal lung collapse, we have a CT scan here. We see that these are the consolidated areas of the lung. There is no air in those areas of the lungs. They are completely collapsed. There's no aeration and there's no air content. And if we look at the ventilation of the different areas, considering that we're still using the same target tidal volume, there's no ventilation in the dorsal area. There is a reduced and expiratory lung volume and reduced ventilation, which results in the shunt. And then the same tidal volume is then distributed in this mid-dorsal, mid-ventral, and ventral areas, but in a smaller portion of the lung. So how would this look on a PulmoVista? So we still look at the 4 regions, the ventral, mid-ventral, mid-dorsal, and dorsal. And usually, as I said, that the distribution of ventilation should be 35 to 45 in the region of interest 2 and 3, and about 10 to 15 in the regions 1 and 4. But in here, in the dorsal area, there is no ventilation. You see, there is no blue color. So, of course, that could mean that our region of interest is not set up appropriately, but it can also mean that there is no ventilation in the dorsal area, which is associated with atelectasis. So, and that is, we're still kind of comparable to the CT scan and the PIT. So let's have a look at the inhomogeneous lung of a patient potentially with ARDS who has dorsal lung collapse. So we have no ventilation here, and we have ventral overdistension. So this is on the CT scan, we see that there is air content. So we see that the air is inside the lung. But we don't know whether this air is contributing to the gas exchange or not. And if we now look at the ventilation, actually what happens, there is no ventilation in the dorsal area. There is almost no ventilation in the ventral area because we have the increased and expiratory lung volume. We still have reduced ventilation. We still have reduced perfusion. As a result, we have a higher dead space. And then we have all the tidal volume ventilating this mid-segment. And that's when I refer to the baby lung. So basically, even if we have lung protective ventilation targets of 6 milliliters per kilogram, we are still ventilating a significantly smaller portion of the lung, which can contribute, and it has been proven, contributes to the development of the ventilator-induced lung injury. So how would it look on the PulmoVista? So again, quite similar. We have no ventilation in the dorsal area because it's completely collapsed. But on the CT scan, we still see the air content. But on the PulmoVista, we don't see the air change. So basically, there is no change in ventilation in the ventral areas. And if there is no change in the ventilation in the ventral areas, that means there is no gas exchange. That means there is not appropriate oxygenation. That means we're still not reaching our ventilatory goals. And that's why PulmoVista is extremely valuable, because we are not looking at the static picture at a point of time, but we are actually looking at the changes in the lung volume. As a result, we are looking at the changes in the regional ventilation distribution. So, and if we look at the screen of PulmoVista, what we have there, we have the dynamic image. So basically this image changes with every breath. So it is synchronized with the patient breathing. Then we have the global impedance waveform, and also you have the advantage of connecting the ventilator, connecting a Dräger ventilator with PulmoVista, and in that case you will get the information about the tidal volume. So this is basically synchronized with your tidal ventilation. So this would be how our tidal ventilation happens. Then we have the tidal image. This is the image at the end of inspiration. So once the inspiration has completed, we will take the tidal image, how the volume has been distributed in the lung. And then we have the regional impedance waveforms, and then we have the regional tidal variation. We're going to have a look at a bit more details on the display of the PulmoVista. So we can use, and the advantage of having a PulmoVista is that we can follow the regional distribution of ventilation over time. We can look at the results of the therapeutic interventions. So we can evaluate patient lung condition during the recruitment maneuver, before the recruitment maneuver. We can evaluate during the recruitment maneuver. We can still see how the ventilation changes after, like shortly after the recruitment maneuver, and we can still see the changes even in a longer term after the recruitment maneuver. So basically, we can continuously monitor the changes in the patient ventilation status, and we can immediately see the results of the therapeutic intervention, be it recruitment maneuver, be it proning, be it bronchoscopy, or any other interventions. So basically, we can do it continuously, we could do it at the bedside, and non-invasively. So let's have a look at what EIT is good for. What can it be used? What can it be used for? So of course, PulmoVista is a great tool to evaluate the responders versus non-responders to the recruitment maneuver. We can also look at the response to the variability in ventilation. If you're practicing size or if you're practicing variable pressure support, you can also see the response to the variability in ventilation. You can check patient positioning. If you practice proning in your unit, you can use PulmoVista even during proning. You can use PulmoVista to optimize your settings. So in general, to look if you are reaching the right areas of the lung. You can also check the effects of chest physiotherapy or even weaning. So PulmoVista has this theory, or it had this image that PulmoVista is a tool that can be used to evaluate the recruitment maneuvers. But actually, PulmoVista can be used in a lot of various cases. And in the next webinar, which is scheduled on July 6th, I'm going to be covering the how PulmoVista can support the image-guided lung protection and also the support of the recruitment maneuvers. Plus, I'm going to address how PulmoVista contributed during the COVID-19 pandemic. So basically, PulmoVista has been also very frequently used in the COVID-19 patients, and there's clinical evidence of the improving outcomes in the COVID-19 ICUs. So if you're interested in this topic, please register for the webinar on July 6th. It's on our Dräger website. So I think it's enough of the PowerPoint presentation. It's been long enough, and I hope I was able to introduce to you the main concepts. And now I would like to actually have a look at the, I would like to have a look at the actual device. So what we're going to do, we're going to look at the PulmoVista. So welcome everyone again. Here in front of me, I have the PulmoVista 500. We have the main control unit, we have the cockpit, and then we have a number of accessories that I would like to introduce to you. So to start with, the main accessory is the cable trunk. So basically, using this trunk cable, we are able to take the measurements. So when we start the device, we of course need to connect the cable trunk to the main unit, and then we have the color-coded two belt extension. On one of them it says R, and on one of them it says L. So this is the right and the left. And if we now look at the cable or the patient belt, we will see that it also has the two extensions that are color-coded with green and red. So the R and the red. So in order for us to perform the measurements, we would need to connect the green to green, and obviously we would need to connect the red to red. So now we would be able to start the measurement. But I would like to share with you a few practical advices on how to best prepare PulmoVista for the use in the ICU. So basically, I would not recommend to connect the cables right away, because the cable positioning can be quite challenging. Cable consists of the two parts. We have the silicone belt. You can see here the red one. We have silicone belt, and we have the cable itself, the signal cable. And you can connect the silicone cable and the cable belt by just easily pressing on them together. So you connect the belt and the cable together. There is also an indication for you for the easy connection. So you see that there is, I'm gonna put your hand. So you see there is a direction, the way the belt needs to be connected, the cable needs to be connected. So you see that this is the direction, and that's how we start to connect our electrode belts. And then we go one by one. We go one by one. We connect. So basically, every connector is numbered, and every electrode should be connected to the right number on the belt. So this is the first starting point. When it comes to the reprocessing, the belt can be reprocessed. It's a multiple use belt. It's not a single use belt. So of course it needs to be reprocessed between every patient. You can use just white disinfectant, and please be careful when you clean the electrode belt to make sure that there is no water or the cleaning agent that gets inside the electrodes, because this may have an impact on the reading. So basically we can use white disinfection. So now, how do we position the belts? We have this midline. We have this midline that should go on the patient's spine. So basically, this is the medium position that needs to be on the patient's side, on the patient's spine. And the way you can position the belt, you can either fold. You would still need the two nurses in order to put the belt onto the patient. One nurse might not be strong enough to do that because one person needs to hold the patient and the other person needs to slide the belt. So there are two ways on how you can place the belt. One way is you can lift your patient and you can keep your thumb on this midline position and you can just slide the belt back onto the patient. And we position it for male patients, it's around the nipple area, and for female patients, it is usually done under the breast. And then once the belt is positioned, you just close the belt. So I can demonstrate this to you again. You can close the belt. And then you would need to use the closing electrode. Okay, so you close the belt, and then you will just need to use the closing electrodes to ensure that all the electrodes are connected. So that's one way of how you can position. The other way is when you have a patient, you can rotate the patient on one side. You can slide the belt in under the patient, but the challenge is this cable extension. Usually this cable extension is the one that gets stuck somewhere under the patient. So whenever I do the measurements in the ICU, I would rather try to, if the patient is, if it's possible to lift the patient, I would rather slightly lift the patient and slide the belt back rather than try to slide it under the patient, because the challenging part is to slide in the electrodes extensions. So basically you position it on the patient, you then make sure that you close the belts. We have different sizes of belts, and as I said, we have recently introduced the pediatric belts. So we are now looking at patient population from roughly about 5 kg. So it's not neonates, but it's small babies. And we have the largest size, I think it's XXL, so we can really cover an entire population in the pediatric and in the adult ICU. So this is with regards to the belt positioning. Once the belt is positioned, we need to, what we need to do, I'm going to demonstrate this to you, we need to do the signal check. So basically, once you position the belt, each electrode will send its signal to the device. And if all of them are below the red lines, that means we have good connectivity, we have good, we have good connection. If any of the electrodes are shooting above the red lines, that means that the connection is not really good. So what we need to do, we need to either add a little bit of the ECG gel or just a little bit of water to ensure better conductivity. So once you have checked the signal, once you ensure that all electrode belts are positioned correctly, we would then can connect the patient belt to the device. So as I already mentioned, you connect the right to right, and you connect the left to left. And that's basically, we are now ready to perform the measurements. So for the purpose of the demonstration today, I'm not going to do the live measurement, but I would rather like to talk to you about the potential clinical advantages that PEEP has in the ICU. And the two examples that I would like to address today is the responders or the evaluation of the recruitment maneuver and the response to the recruitment maneuver. So let's have a look on the display. So in the device, we have already preloaded. Sorry, just froze a little. So we have already preloaded the recordings of the stimulation files. So we have previously recorded a collection of clinical files, and we have loaded them onto the screen, and we are now able to demonstrate using this simulation. So in your clinical practice, you could also record every single measurement that you take with PulmoVista. So basically, just as a reminder, whenever you start the PulmoVista measurement, press the record button, and then the recording will be available to you in the files. So unfortunately, I have to restart my PulmoVista, so we're just starting with it now. Yeah, so today, as I mentioned, we're going to talk about the responders versus the non-responders to the recruitment maneuver, and basically we will try to analyze how the data from PulmoVista translates into the assessment of the ventilation of the patient status. So we'll just need to wait a few more moments. The device is starting up. I'm going to switch to the main view. So basically, we start in the standby menu, and what we can do, we can go into the system. Let me just disconnect this. Disconnect this. Let's have a look. Okay, so we go into the simulation, and we see here we are loading the responder to the PEEP trial. So we can start. It will take some time to load the simulation data. Takes just a few seconds, and then we will be able to start with the simulation. We have different types of files. And for those of you who have a PulmoVista and are interested to learn more about it, we have files on the responders group, recruitment maneuver, non-responders. We have a file on the obese patients. So there are really a lot of different information. So we can now start with our simulation. And what we basically see on the screen is the dynamic image. So this is the breath by breath image. We have the tidal image that is showing the ventilation distribution at the end of inspiration. And what's interesting enough that we already see that there is no ventilation in the region of interest 4. How do we see that? So basically, normally our ventilation distribution should be quite equal in all 4 areas of the lung. But we see here, usually in the region of interest 2 and 3, there should be about 35 to 45%, and in the region of interest 1 and 4 should be around between 10 to 15%. In our case, we have almost no ventilation in the region of interest 4. So what we can potentially estimate, or what we can conclude from this when we connect PulmoVista to the patient, is that potentially we have a patient with the atelectasis. So we have de-recruited areas of the lung. And as a result, we would try to perform a recruitment maneuver. So now in the simulation file, we will soon start with the recruitment. So this is our main view. In order to evaluate the success of any therapeutic intervention, we need to go into the end inspiratory trend view. So if we look into the full screen view, this is usually just a demonstration of the dynamic image, plus this is also the demonstrating the global impedance curve and the regional distribution of the ventilation. So as I mentioned, in order to perform the analysis of the therapeutic intervention, we need to go into end inspiratory trends. So now when it actually gets interesting. So we will try to refresh this, and our simulation file here is restarting. So what we now can do, we can estimate the success or the impact of the recruitment maneuver on the patients. So what we need to do, we put the reference cursor, our cursor, blue cursor, at the start of the measurement. So basically, this would be our starting point. And we look at the tidal image at the point of reference, and we see that there is no ventilation in the region number 4. So we see there is no blue color in the region number 4. And if we also look at the so we can see here that there's no ventilation. And if you look, we have tidal volume of about 660 milliliters with a PEEP of 5. And we have no ventilation. So now what we have done, we have performed a recruitment maneuver. And here we don't really provide recommendation which recruitment maneuver to use. You can use whichever recruitment maneuver you are feeling comfortable with. It can be either a 40/40, it can be an incremental PEEP, it can be a cycle, literally any of the recruitment techniques that you use. And we now evaluate the success of the intervention. Therefore, we put the cursor 1, to the time frame after the recruitment. So we've done the recruitment, and we now we perform the recruitment maneuvers. So how do we know that? Because we have the information about the pressure. So this is our PEEP, and we increased our PEEP. So, and we see, what do we see now? First of all, we see that there is a blue color in the dependent region in the lung. The region of interest 4, we have now blue color. So that's the first indication that we have been successful in opening our lung. But what is the better way of comparing this? We have this change image, and this change image basically demonstrates the difference between the tidal image at the point of reference and the tidal image post-recruitment. And then we have we have different colors. So the blue color, this cyan blue color, means increase in ventilation. The orange color means decrease of ventilation. And we can see here that, okay, even on the cursor, image 1, we see that their ventilation has improved. We also see that the ventilation in this dorsal area has also increased. And if we now compare the tidal ventilation distribution in the region of interest 4, we went from 3% to 12%. So that means our patient has responded positively to the recruitment maneuver. However, we know that post-recruitment, we cannot ventilate our patient on this very high level because we went from people 5 to the people 14. So now we need to find optimal ventilation settings for our patient. So we need to find optimal PEEP. And in our case, we have done a decremental PEEP trial. So, and we see that basically we can see we were over extended period of time on the people 14. So what do we do now? We put our cursor onto this post-recruitment stage. So that's when the lungs stabilize. That's when we know that we have opened all the dependent regions of the lung. And we now start to evaluate the decremental PEEP trial. So we put the cursor 1 to the next level of PEEP. So we were at PEEP of 14, and we went down to the PEEP of 12. If we compare the two images, there is no changes. Basically, it's almost black. There is no increase in ventilation, neither there is a decrease in ventilation. So we can successfully and safely go down from the PEEP of 14 to the PEEP of 12. So the next step would be to go to the next level of PEEP. So we take cursor 1 and we go down. What we notice here, if we compare the two images, the PEEP of 14 and the PEEP of 10 now, we see there is a slight, and I might adjust a little bit to make it brighter. So you see there is a slight orange color. You cannot see it very well, but so now there is a slight orange color, which demonstrates to us that potentially there is a start of de-recruitment. Potentially we are losing ventilation. We're starting to lose ventilation in the dorsal regions of the lung. So the next step would be to evaluate, can we go even lower with our PEEP trial? So now we're at PEEP of 10, we go down to the PEEP of 8. And what we see, we are now losing a considerable portion of the lung, lost ventilation. We also see that there is much brighter orange color and much bigger area. And if we compare that we went from the tidal ventilation distribution of 13% down to 2. So we lost completely the benefits of our recruitment maneuver. And if we now go even further down, we see that the tidal volume drops, and we see that there is no ventilation in those areas whatsoever. So now we can make a decision to whether to either now we need to make a decision which PEEP level we should use for our patients. So, and the choice that we have, we can either stay at 12, where there was absolutely no change in ventilation, or will we go to 10, where there's a slight decrease, but still not substantial. So once you've done that decision, what we need to do, we need to perform another recruitment maneuver to open all the collapsed areas of the lung. So we perform the recruitment, and then we go back to the PEEP of 10. So basically, we have conducted a recruitment maneuver, and we evaluated the success of the recruitment maneuver in real time at the bedside, together with the ventilator, together with the patient. So, and we were able to find optimal settings for this particular patient. Let's have a look at a different example. So I would like to demonstrate to you the non-responder. So that is also quite an interesting example, the non-responder to the recruitment maneuver. What you would see on your PulmoVista once we perform a recruitment maneuver on the non-responder. So the file needs to load as well. And once the file loads, perfect. So we start with the ventilation. So again, we start with our ventilation, and we see that in the dynamic image, we have limited ventilation in the dorsal area. So we have almost no ventilation, 5% in comparison to our usual 10 to 15%. So again, we can come to the conclusion that potentially these areas of the lungs are collapsed. So what we decide to do, we decide to perform a recruitment maneuver, hoping to open these collapsed areas of the lung. So again, in order for us to perform the analysis, we go into the inspiratory trend view, and we now look at this. So we put our cursor at the start again. So this would be our starting point, and then what we do. So we put both cursors at the same level, and then we perform the recruitment maneuver. We wait for the lung to stabilize, and then we compare the two images. This is the reference image at the reference cursor, and this is the image post recruitment. And we see here, first of all, there is no increase in ventilation. There is no increase of ventilation. What happened though, we have lost ventilation in the ventral area, because remember I said orange color means reduced ventilation. So what can this tell us about our recruitment maneuver? Well, first of all, we have not opened the dependent regions of the lung. There is no change in the ventilation. And what we could have done, we might have also contributed to the potential over-distension of the lung, of the ventral areas of the lung. So you see, because we lost ventilation in the ventral areas, and if you lose ventilation in the ventral areas, what it can tell us is that potentially there is a risk of over-distension. So now we want to, first of all, we already see that the patient has not responded to the recruitment. If we now perform the decremental PEEP trial, so we start at 14, we go down to, for example, we start at 14 and we go down to 13, no change. We go down to 10, no change. We go down to 9, almost no change. So basically, our intervention has not translated in any improvements. We were not able to open the lung, and we have potentially caused the lung injury associated with excessive pressure, potentially contributing to the overdistension of the lung tissue. Maybe just for a short period of time, but then once you see that your patient is not responding to the recruitment maneuver, you might not continue with the recruitment maneuver. You might you might opt for an alternative like proning, for example. So we might make an informative decision based on the regional ventilation distribution at this point of time with this particular patient. So you have a bit more information on how to adapt your therapy for this particular patient. So yeah, this is basically what I wanted to demonstrate to you on how PulmoVista can benefit you, some of the clinical benefits of the PulmoVista in the clinical practice. So we just addressed two very simple examples, the responders versus non-responders. Next week, I will do a more, next webinar on July 6th, I will do a more in-depth analysis of how to best optimize the ventilation settings using our diagnostics view. So we can now perform an automated diagnosis of the PEEP trial. And I will also explain on how to interpret the data of this diagnostics view. So this is going to be covered in the next webinar. This webinar, I just wanted to demonstrate some of the advantages that PulmoVista brings. And that brings me to the last point on the agenda, which is the clinical evidence. So I know that we have a lot of participants from Japan today, and I'm very excited to see that many participants from Japan, and I think they might be familiar with this case from the key opinion leader in Japan, Dr. Toro Kotani, who one of the first users in Japan have been trying PulmoVista in clinical practice and have been doing quite a bit of research with PulmoVista in the clinical practice. So this is an excerpt from his older publication where he was evaluating the patient positioning. It's a case example, patient positioning and evaluation using EIT. So basically, they had a 77-year-old female patient who was severe hypoxemic, who was diagnosed with ARDS, who had experienced respiratory acidosis, and they have made a decision to prone the patients. In the first 20 hours, the patient has been ventilated in pressure control, assist control ventilation with the inspiratory pressure of 28 millibar and the PEEP 15. It's quite high settings, or I would say it's very high settings. So, and we have limited possibilities on what can be done with the patient. So that's why they have decided to prone the patients. And for the next 2 days, they were ventilating the patients, this patient in APRB on the high pressure of 28 millibar and FiO2 90%. And basically, they put a PulmoVista to identify the non-ventilated areas of the lung, to monitor patients' response to prone positioning, and to support the decision to continue or discontinue patient proning. So basically, they wanted to see if this patient in particular would benefit from proning. And what they've done, they measured the initial conditions, and we see that we have extremely small area of the lung that is being aerated, that is being ventilated. And then they have performed their first proning, and you see that there was already an improvement in ventilation. And then 20 minutes after the second proning trial, we see a substantial improvement in ventilation. So they were able to evaluate the results of proning in real time, also in the longer term continuously. And basically, they started with the regional ventilation distribution, with their ventilation distribution in regional interest 4 with 0. There was absolutely no ventilation. That was the tidal image 1. So they came to the conclusion to continue with proning. They have performed the first proning trial for about, and then they made the measurements 20 minutes after the start of the prone position, and they saw already an increase in the ventilation distribution in the region of 4. So, and you can see that the conclusion was that the proning of the patient improved distribution of ventilation. The prone position was discontinued after 3 hours as there was no further improvements, and PIT could not detect any further improvements. And then the second image have been taken after the second proning trial. And we see that we went from 0 to 16%. So we can see that our patient has substantially benefited the proning trial. And until day 9, that patient remained hemodynamically stable. Unfortunately, the airway pressure could not be reduced because of the alveolar instability in supine position. And on day 10, they have switched to the APRP with the pressure high 26 millibar and the pressure selection, so the pressure setting on the PulmoVista, the pressure setting on the ventilator has been guided by EIT. So basically, they were looking for the lowest pressure without the dorsal de-recruitment. And they continued with the proning for 14 days for the period of less than 7 hours because they did not see any further improvements over a longer period of proning. They have not noted any adverse effects associated with prone positioning. And on day 32, patient was weaned from mechanical ventilation. And on day 200, the patient was discharged. So this is an excellent example of how PulmoVista can be used not just during the recruitment, but also during the patient positioning. So in this case, proning. And the PulmoVista helps them to time and monitor the use of patient proning. It helps assessing the extent and the location of the patient's lung pathology. So basically, it helps evaluate which regions of the lung were not ventilated and were potentially overextended. It assessed patient's ability to recruit, to respond to the recruitment, and also evaluate the homogeneity of the gas distribution. And it also helps ensure long-term stability of the lung condition of the patients. And it's not just one example. There are multiple cases, there are multiple publications available talking about the different aspects of using EIT. So in this study by Wolf and the group of Wolf, they looked at the PEEP titration using the EIT. So basically, they compared the mechanical ventilation guided by electrical impedance tomography in the experimental acute lung injury. So basically, they used the real-time electrical impedance tomography to guide lung protective ventilation in an animal model of acute respiratory distress syndrome. What they have done, they have performed incremental lung recruitment, and then they performed the decremental PEEP titration. So we can see basically their protocol of recruitment and then the protocol of PEEP titration. And what they have discovered is that they reverse or they reverse the atelectasis in the dependent regions by raising the PEEP in the gradient of 5. They reduced the overdistension and they were able to maintain the current PEEP. And in summary, this approach was to open the dependent lung regions and also to subsequently reduce the PEEP settings. And in the control group, they used the ventilation according to the ArcNet table. And as a result, what they have discovered is that they have improved respiratory mechanics, they have improved gas exchange, and they have improved they have reduced the histopathologic features of the ventilator-induced lung injury using EIT-guided PEEP settings. So basically, EIT-guided PEEP settings resulted in more lung protective, individualized ventilation settings in the animal models. Also, another study that also basically looked at the PEEP titration using the EIT, that's already the group of Marcelo Amato, and what they have done, they had two strategies of PEEP titration. One was the EIT method. So basically, they performed a recruitment maneuver of 2 minutes in pressure control mode. They reached the inspiratory pressure up to 60 millibar. And after the recruitment maneuver, they have performed a decremental PEEP titration from 26 centimeters to 10 centimeters of water. And then they have selected the optimal EIT PEEP, where they basically opened the lung and kept the lung open. In the other group, in the control group, they were using the esophagus pressure measurements to find the optimal settings for the PEEP. And as a conclusion, they also came to the conclusion that in the model of severe ARDS, the choice of PEEP guided by EIT leads to higher lung recruitment and physiological signals of a better lung protection when compared to the strategy guided by the esophageal pressure measurements. So again, the EIT guided PEEP has proved to be more safe or more lung protective, at least in the severe ARDS model, patient model. Of course, now there are researches available on the real patients as well, and especially there is a lot of evidence when it comes to the COVID-19 patients, and I'm going to cover this in the next webinar. But we already see that even in the ERDS models, we see a significant improvement in the optimization of the ventilation guided by EIT. So if we look at the summary of EIT, what PulmoVista is capable. So basically, it monitors the regional distribution of ventilation continuously. So at the bedside, continuously monitors the impact of mechanical ventilation. It is able to quantify the regional changes in the end expiratory lung impedance. It also helps assess the changes in the regional lung compliance. It is now possible to monitor esophageal pressure with PulmoVista. And we also have a webinar on August 5th, where we're going to cover on how PulmoVista supports and performs the esophageal and transpulmonary pressure measurements. So as I mentioned, today is the first webinar of the series. We will have a second webinar on July 6th and the third webinar on August 5th. And on August 5th, we will cover the transpulmonary pressure measurements. And of course, PulmoVista can help us assess the response to the therapy. Either could it be a PEEP titration, managing tidal volumes, recruitment maneuvers, patient positioning, lung function. So with this, I know that it's been rather a long lecture, and I hope I was able to keep it interesting. So now we are open to questions and answers. And in the meantime, I would like to thank you all for attending today's webinar. I hope it was informative for you. I hope that we were able to share some of the clinical benefits of the EIT and of the PulmoVista. And if you would like to learn more, please visit our website to learn more about the electrical impedance tomography. Okay, so there is a question. Does it decrease the thoracic compliance? That is an excellent question. And I'm very glad that this question has been asked because it's very important how the belt is positioned. And as I mentioned, I'm going to just disconnect the electrode. So what is very important is that you select the right size of the patient belt. So as I mentioned, we have from the smaller ones, the XS to the XXXL. So basically, we have a measuring tape that you can measure the chest circumference of the patient and find the optimal size. So the belt needs to be positioned tight enough to get the good signal, but it should not be the case that your patient is squeezed by the belt, because in that case, yes, it will have an impact on the thoracic compliance. So most importantly is when you position the belt, you just perform the signal check to ensure that we get the appropriate signal from all the electrodes. But the patient should not be basically suffocated by the belt. You see, the belt is elastic and the electrode is positioned in such a way that they can easily stretch. So even if we stretch a little, it will not have a significant impact on the thoracic compliance. But if the belt is too small for the patient, we might have pressure for it and we might have an impact on the thoracic compliance. Okay, thank you for the question. And I think so far we can actually close the session today. I'd like to thank you all for attending the webinar. At the end of the webinar, we will have the survey. I would really appreciate if you could fill in the survey and share your feedback with us so we can improve for the next sessions. So thank you, and I would like to wish you a great day. And we will reconnect in July for our second webinar, image-guided lung protection. Thank you, and have a nice day.